Is that working for you? Or?
I don't know how to get the actual PowerPoint into the box.
So if you just open up your PowerPoint and have it on your desktop, okay, so then at the bottom of the Zoom screen that you're seeing, there should be a green box that says share.
Mm-hmm.
And then you click that.
Ah, got it.
There.
All right. Can you all see that?
Yes, we can.
Okay, so this part is just super basic, and of course we'll expand upon it. So I guess one of the things just to note about this is it always is a little bit tricky and complicated, right? Some of the questions or scenarios that were sent to us ahead of time, it's, you know, it doesn't always seem like there's a super clear-cut answer, which I think is why people get a little bit frustrated with this area. But we've been doing this, we've had behavioral health services since 2009, have been offering medication-assisted treatment since that time as well. So we have a good bit of experience in this, but I can tell you it's been a really big learning curve for us as well. And we're constantly seeking answers to questions that we have regarding this as well. And we did consult with our in-house counsel and our director of compliance just on some of these questions as well to make sure that we were giving the most accurate information. So I think you all know, but just some background, we're a federally qualified health center in West Virginia and southeastern Ohio. We also serve a lot of patients from Kentucky, and we've been in operation for about 40 years, and we see around 70,000 patients annually. We do have an integrated healthcare system where multiple service lines share the same electronic health record. I know that question came up a couple of times. So that includes OBGYN, internal medicine, family practice, pediatrics, optometry, behavioral health. We also have dental services and so forth, but those are housed in a separate EHR. So in terms of confidentiality, just some background in terms of what we do. So we use an electronic health record, and one of the questions came up about sharing that, which we'll go into in a minute. But one thing, just as some background for you all, is we use Greenway Entergy as our system, and we have the capability for our behavioral health providers and any provider really to default their notes to confidential. So that's one precaution that we take, is rather than being able to see all of the documents and the provider name and the title of it, it's defaulted to confidential. You have to go through a special override process, and so it's further tracked throughout our system. And we also, but even though we do that, we're not able to separate out all information. So you still have a shared med list, you still have a shared diagnosis list, which is why it's important to continue to build into your consent forms that, you know, you do have an integrated electronic health record and you will be sharing that information. So a helpful way to inform patients of this is through your registration and your consent to treatment process. If you have a medication-assisted treatment program or a substance use treatment program, we build this into the consent process when they start into that treatment program, and also understanding when 42 CFR Part 2 applies and when it doesn't, because I know that's also been confusing to some people as well.
Hey, Rachel, can I interrupt you real quick? Would you mind hitting the display settings? Because we're seeing like the background of your PowerPoint. Yeah, and then just switching it. Yeah, swap.
Aha.
There we go. Thank you so much.
You're welcome. So I think just next, and anyone feel free to like jump in and interrupt and ask questions. But these are some of the questions that came to us ahead of time. So the first one is, should behavioral health information be recorded and housed privately from primary care information? And I think it kind of went on with like, what are the ethics, best practices of doing that? And I think there's a couple of things. Ideally, from our standpoint, best practice is to not have a fragmented healthcare system, and so to have an integrated one in which you're truly providing holistic care to your patients, because all disciplines are able to see what services they're receiving. Now, same thing with any confidentiality, it's on an as needed, you getting that information is as only when you actually need it or as appropriate. So from our standpoint, we really encourage our behavioral health providers to document more in a progress note fashion rather than process. So that way there isn't not documenting in the traditional psychotherapy realm that we've seen previously, or that you see in some of the non-integrated settings. And then also we have other safeguards in place, like defaulting notes to confidential, because that just gives everybody a little bit, gives some of our patients some peace of mind, as well as other staff members, so those things just aren't open and people can see them pretty easily, whereas opposed to when they're confidential, it takes a little bit more work to actually see that note. And then we were also asked a question about what is the best way to track and let other providers know about sensitive yet off-topic information. And I think it really depends on the nature of that information. And I think, Dr. Hackman as a provider can probably elaborate on how he communicates with other providers about that. But if anyone also in this group has a more specific question about what type of information, whomever asked that, what type of information they're looking to share, and they're concerned about how to share it, if they can share that specifically, that would be great.
Yeah, I think it is very much a case-by-case basis when we're talking about that information. I think it is a learning process. There has been examples where in a psychiatric intake note, of course, I go over, a biopsychosocial history and talk about, trauma events and sexual abuse history. And one of the primary care doctors kind of copied forward using the forms, using our EHR, inadvertently copied forward my social history rather than their social history. And then the patient was very upset to find that in their primary care notes. So I think it's important to, when you are rushed in your primary care clinic, to just kind of be aware of what things are going in your notes and that they should be in your notes. So examples like that wouldn't happen. But as far as communicating with the other doctors, I think it's, if it's separate sites, you can talk through EHR. Sometimes if you don't want something like a task or a message to a primary care doctor to necessarily be discoverable in the patient's chart, should they ever get records, then you can always kind of de-identify the message. Ours is able to do that. I don't know if everybody else's is. But also just, hallway consults and talking about them in between appointments is also a good way to do that. Did anybody have any specific example of what type of information you guys were concerned about? Negative?
Okay. Well, if you think of something, let us know. But our EHR, again, has the capability of sending a message that's not attached to a patient chart, which is really helpful to communicate between sites. All of our providers also have each other's phone numbers. They communicate regularly through that as well. And again, we tell our patients on the registration form, we outline our different services, and we include in there that your providers will discuss your care as appropriate and necessary. So if Dr. Hackman's seeing somebody and there's information that would be pertinent to the treatment with their PCP, then he's going to make that PCP aware of that, and it's covered in our registration and consent form. Again, it's only the information that's needed. That doesn't mean that Dr. Hackman then needs to share all the other information that's been discussed with that patient in their sessions, but that information which could impact their care with the PCP. So this one is pretty straightforward. It's asking about, someone had sent a message about what age can a minor give consent. So for birth control, prenatal care, substance use treatment, or STD testing, minors can give consent, and parents do not have a right to that information without the minor explicitly giving the consent. So for other medical services, including like general outpatient mental health services, so if it's non-substance use related, but maybe it's for anxiety, depression, so forth, Parents generally have access to that information unless there's an exception. So those exceptions are if the minor's been legally emancipated, or they're 16 years and over and they're married, or they're considered by the provider to be a mature minor. So this is determined at the provider's discretion, and you do need to document it in your note. And oftentimes the reason that the mature minor part comes up is if there is a strong conflict between what the minor is wanting to do with regards to their medical care and what the parents are wanting to do. So you have a 16-year-old who is being seen in the primary care practice, and they have a strong, depending upon whatever the medical condition is, they have a strong feeling this way, and it's super contradictory to what the parent wants to do. I think that's oftentimes where you see a provider making a judgment about the patient's maturity.
Like a Gardasil?
Yeah,
Immunization?
yeah, you could think about maybe the HPV vaccine as being one of those areas. And if the person is, 16, 17 years old, that's up to the provider's discretion. I think we always still try to encourage open communication and transparency when those issues are going on between parent and child, but sometimes you're not able to get everybody to meet on the same page. Are there any specific questions about that issue?
Regarding the designation of mature minor, and speaking with one of the providers here, she said that, and she actually said that this has come up with her specifically when it comes to when a woman or young lady becomes pregnant, and I guess the law in West Virginia, then it's no longer covered under CMR, and technically, I guess parents now can have been made aware of that or something to that effect. And she said that what she has is there's a form that is needed and that she fills out that provides or establishes that designation of mature minor. Is that a standard form? Is it something that maybe she's just using? Yeah.
I'm not aware of a standardized form, but I can definitely ask our in-house counsel. This isn't something that frequently comes up for us, and we have a pretty large peds practice. Now, we do a significant portion of family planning, but that's, getting access to birth control and prenatal care is covered without needing consent from the parents. And so, but if it's for other medical services, we generally don't have a lot of just like general services that are going on where we're running into the need to designate somebody as a mature minor, but I can definitely look into that with our counsel. Because I think a standardized form would really help, because I think providers are really, it's a gray area to designate somebody as a mature minor, right? But I think in most cases as a provider, you use your best judgment and you document appropriately as to why you made the decision that you did, and evaluate, risks and, benefits and so forth to doing so. Are there other questions on that topic?
I think that you probably kind of touched on this, but I didn't quite hear. Is there a different designation with consent and confidentiality, regarding behavioral health records and minors, or?
So that still falls under the age of consent being 18. So no, it's just substance use treatment, STD testing, prenatal care, and birth control. So parents nor adult patients have a right to have access to their psychotherapy notes under HIPAA. So we oftentimes do have adults come into us, and they've already consented for their child to be under our care for, say, maybe they're being treated by Dr. Hackman for bipolar disorder or anxiety or depression, what have you. We do get parental consent for that service. And say they're also seeing a therapy provider in conjunction with that. If they come in and they request the psychotherapy notes for that child, we do not have to actually release the psychotherapy notes to the parent, nor if the person was 18 years and over, do we have to release them to the actual patient. It's up to the provider's discretion as to whether or not they feel releasing psychotherapy notes would be harmful, right? So if the child is talking about their home life with their therapy provider, right, and talking about things that are going on between their parents, then the provider needs to be able to make the determination to say, it's not appropriate to release these records. I'm just going to go ahead and write a treatment summary instead.
Okay. So you kind of leave it up to the provider's discretion, whether it's disclosed. Okay. And like with your like documentation, do you, like, for example, say a minor was using marijuana, but that wasn't like a focus of treatment, would you add that to like a problem list on the general medical record, or do you keep like those types of things like confidential that come from like behavioral health visits?
I would. If they meet criteria for, marijuana use disorder, then yes. If it's a kid that smoked pot, at a party last week and it was the first time, absolutely, yeah, I wouldn't.
Okay.
And even before I worked for an integrated system as a resident, I was a huge proponent. We need to be transparent and clear, and let, if you're using a shared electronic record, the other providers, if they are taking care of a patient, they should know what they're being treated for by us. It just helps them give more, 360 care to a patient, and not be scared about adding borderline personality disorder to the medical record or marijuana use, because it is part of the patient's, presentation.
Would that be something that you would disclose? Like if a parent, requested medical records, then would they have access to that diagnosis?
So it depends. So I think so this is the next one. I think that touches on that. So this is where 42 CFR Part 2 takes place, as well as a minor giving consent to receive substance use treatment services. So, so say I'm 16 and I go see Dr. Hackman and I tell him I smoked marijuana once or twice, but I don't meet criteria for a substance use disorder, I'm not in substance use treatment. I'm still receiving services for my anxiety or depression, but I'm not actually enrolled in a substance use treatment program. So That's one thing that's really important to differentiate. So, which is what confuses everybody with 42 CFR Part 2. If I'm a PCP and I see somebody and they report they have opioid dependence, or I diagnose them with opioid dependence, but I'm not really holding myself out as doing substance use treatment, then certain regulations don't apply. So we put on here, like if the teen is actually receiving substance use treatment services, then no, like a PCP or other medical provider, if it's a psychiatrist, what have you, cannot tell the parent without permission from the teen about their diagnosis, about their treatment, about drug screens, and so forth. So technically, I think that there's a question asking about liability, or could the patient take legal action against the PCP or other provider because it's in a protected category of substance use treatment? I would say no, because the patient's in receiving substance use treatment services. Now, if the teen is being seen in primary care, so say I'm 15 and I'm being seen by primary care or psychiatry, and I'm receiving a stimulant medication, and so I had to do a drug screen at one point in time, and the drug screen showed positive for hydrocodone and so forth like that. I'm not in substance use treatment at that point in time, and so it is okay to tell the parents. Now, you could very quickly shift differently though, and after that session, the adolescent could then become engaged in substance use treatment, and so pretty much from that point forward, you may not be able to share information after that.
Okay. Yeah, and I think I think part of it is, and my questions are like in how our electronic health record is set up, because I know like typically if a parent would request information, I would do a treatment summary, and so if an adolescent might come in and say, I use marijuana daily, or something like that, and so that might be something like maybe they fit criteria for marijuana use disorder, but maybe that's not why they're coming to see me. They don't want to, they don't want to deal with that, whatever. If I document that in our medical record, then that becomes part of something that would then be disclosed to the parent just because of the way our like records are set up. And so I guess that's where I'm coming from is it like are there things like that that are able to be kept confidential from parents, or if they have a diagnosis of, you know, whatever substance use disorder, is that something then that has to be disclosed? Do I need to tell my adolescents, hey, you know, if we start talking about this, it's going to get out to your
parents? I don't know that I'd say that it has to be.
So for your specific records, why is it that you say that it's pretty much guaranteed that the parents are going to find out about it? Like what happens?
Well, it's not guaranteed. Like if they requested the medical record.
Oh, okay.
It would then be part of the medical record that would be released, unless it's kind of like kept separately, if that makes sense.
Yeah, I think what Margie's saying is it's one of those things where it doesn't seem, we can't guarantee we can't say that information will be discovered by their parents, but we can't guarantee
that it wouldn't be.
Yeah.
Okay. I mean, I usually use those instances as a stepping point for them to start having conversations with their parents about what they're doing and what they're struggling with. Because, you know, in an example of a stimulant, parents going to question why I quit prescribing it because the kid couldn't quit smoking pot. Right. Or if it is, you know, becomes an issue, letting the kids know that, look, you know, this is a thing, your parents really do need to be knowing about what's going on. I think we need to engage them in a conversation, because, you know, eventually they may find out about it, whether it's from us or from, you know, the fact that you got arrested because you were having a quarter ounce of pot in you at school. So I think it's just more, rather than so much worrying about keeping patients' confidentiality in those instances, focusing more on how you can best care for the patient and help them out.
Mm-hmm.
Well, yeah. And then, sorry, go ahead.
Oh, no, go ahead.
I was just going to say, so then for informed consent purposes, it's then maybe really critical to be very clear that kind of information might not be kept private or might not be able to be kept private.
Yes, and if that's not okay with them, so that's what our form says. Like if they're not okay with the fact that we have a shared health record and that information is going to be seen by the PCP, which then means like that it can be printed out, then we have to arrange for care elsewhere. And I know that's really hard in rural areas, but usually I think we find that most people are okay with it. I think as long as you're having that discussion up front with them. And one thing I'll clarify with our in-house counsel, because 42 CFR Part 2 is just really challenging, especially as it relates to integrated health records. But I'm so inclined, you know, if you're providing therapy services to a 15-year-old and yes, at some point in your assessment, you diagnose them with a substance use issue, but you don't hold yourself out as providing substance use treatment services. I don't know then that teen is actually falling under that category of, you know, information not being able to be shared with their parents without their consent, if that makes sense. Mm-hmm. You know, a diagnosis is different than treatment, because PCPs diagnose children and adolescents in their practice, because we do screeners, right? I'm sure you guys do. So we were doing screeners on individuals 12 and up. So for that person who comes in and they're, you know, 15 and they're answering yes to all these questions and it's maybe evident that they have an alcohol issue, our PCP is probably going to put that on their problem list, right, after they have that discussion. So, but our PCP doesn't hold themselves out as providing substance use treatment services. That makes sense.
Yeah. I think, David, that was exactly my point, is that I feel like we need to be able to have those conversations really like in our primary, like with our primary care visits. Like if they're being screened for stuff, ultimately that can get to their parents. So they need to know before they're filling out those screeners and those kinds of things. Because I work in a school-based health center and kids are way more open about what's really going on when their parents aren't here. And so we get a lot of really good, helpful information, but they may not be willing to tell us that if their parents are going to find out.
I think to be devil's advocate and throw out a worst case scenario halfway through this, one could argue that if you are talking to a kid about pot and you the following sessions are focused on reducing pot, and if you document engaged in motivational interviewing or something like that, you're kind of entering into the treatment area, because the reality is it's not like there's a MAT program for pot.
Yes.
And so if we're defining substance abuse treatment as an MAT program solely where a medicine is prescribed, well, there's no such thing when it comes to marijuana. So I would just be careful at that point if that is becoming a focus of your sessions, that this is looking like treatment, so therefore he's protected.
Yeah. We have in our school-based health centers an SBIRT program. So we are screening everyone that comes in for a well child. Are you using substances? How much are you using? Like those kinds of things. And then, trying to do some brief intervention if it's like, we're not meeting criteria for a substance use disorder. And then obviously referring to treatment if they are. So we are asking these questions and the kids are assuming that this is not something that mom and dad are going to find out about. I really think they would be very unlikely then to be honest on these if they knew like mom and dad are going to be able to, they could possibly access this information.
I have a similar question related to is there any protection for minors regarding information about their sexual orientation?
No.
Nope.
No, and that's on our registration form now, as I'm sure, because I think UDS changed a couple of years ago to include sexual orientation and gender. What we have done, actually, because this did come up, I'm trying to remember exactly. This came up with one of our therapy providers, and so she actually, so she told the individual who I think identified as transgender and had, indicated that parents may have access to the records at some point in time. And so the therapy provider had a discussion with the patient and said, look, I want to respect your wishes and call you by the pronoun in which you are asking me to. I also want to make you aware, though, that these records may be accessible to somebody else. So they gave the patient the choice. How would you like me to document? And the patient said, I want you to document what my parents are aware of and what my primary care provider is aware of. But they appreciated the transparency in that discussion of this is, I want to be able to respect you by doing this. But if you ever see your notes, if you ever look at this, you may see this, but know that I only did it for the purposes of not allowing others to see when you don't want that. That makes sense.
That's an example of where my usual mantra of let's make everybody aware of everything so that we can take the best care of the patient. When it comes to gender or sexual orientation, the patient needs to be ready to make that public. And so I think the therapist in that situation, I didn't even hear about that. It seems like they addressed it pretty darn appropriately, or as best as the situation allowed anyhow.
Can I ask a question that's sort of related to that? The idea of the designation of a psychotherapy note versus a progress note, content-wise, I understand the difference, but when it comes to actually how it's potentially designated in a person's charge, like shared charging, is it something where if it has a behavioral health designation as the encounter, at that point it's automatically it can automatically be classified as a psychotherapy note, or is it a progress note unless some other stipulation? And then actually, and this is sort of kind of like a overarching question I have. One of the things that I've struggled with particularly is trying to find the actual language and whatnot that I can really lean on and say, okay, this is the reason why we have this, or we have these types of policies and practices. can I ask, I mean, is most of this information coming from your legal counsel, and is there any way that there's they could provide the citations of where this rationale is coming from? I know that's kind of a big ask.
I guess in terms of what specific area, like with minors or with substance misuse or?
Yes, in the sense of yes, in the sense of because I think for me at least it seems like CFR 42 Part 2. I've been able to find good sources and good information on that, but a lot of the other stuff, particularly when it comes to being able to consent for treatment, the mature minor stuff, things like that. That kind of information, I've found some stuff here and there, but if I'm not a lawyer, simply put. So, yeah.
No, and I was doing some research prior to this too, and and I can send all the information and talk with her as well about there is like it's a pretty actually like great fact sheet about West Virginia laws that clearly explain this is when a minor has to can give consent on their own. This is what's protected under it. This is what a healthcare provider has to do. And this is when parents actually have access to information. So it's a pretty good fact sheet. So that way too, I mean, if you needed to show it to somebody else and you can say, look, here's this information. So yeah, we can definitely pass that along. Will you remind me of your first question? Oh, psychotherapy notes.
So I think we have it in our EHR where they're at least all designated as confidential if they're psychotherapy note or behavioral health med management visit. It's just a setting that we do that adds that extra layer of protection. But as far as releasing records,
we treat every note as a psychotherapy note, even though they're not. So because we've had from the therapy providers, because we've had a challenging time getting all therapy providers to document in the same way. But one thing that we can do, if it'd be helpful for you, but I think you could set up encounter notes, and if it's titled this, then your records department or somebody knows it's a true psychotherapy note. If you title it behavioral health progress, then it's a little bit different. So a couple of our providers, specifically the ones who went to Cherokee and did their internship there, they're under the mindset of my patients should have access to their records, right? I want them to always be able to see their notes. There's nothing in there that they shouldn't be able to see. So they document in a very specific way, and we could actually have them provide certain examples of that if that would be helpful, because that's their whole mantra. They're that they should be able to see exactly what happened that day, whatever I documented. And so, but they're mindful of that, of course, when they're putting in the computer and who else can see it.
Thank you.
You're welcome. Any other questions on that one?
This is Jennifer Boyd. I jumped in late. I'm so sorry. This is a very interesting conversation. I'm a PA. I work at New River Health Center, and I work in one of our school sites part-time. My question, I don't think you've covered it, is I find it thorny, but maybe you can shed some light, has to do with confidentiality vis-a-vis outside agencies in what might be a crisis. And specifically, I one time had a situation where law enforcement showed up looking for a teen, I don't remember how old she was, this was many years ago, who had run away and was in the health center at the time. And there was tremendous difference of opinion in our organization about whether or not it was appropriate to disclose to law enforcement. And I know that one model that I've heard is that that when there could be danger to the child, that you can err on the side of disclosing to, obviously CPS is the easiest example to come up with, but I just wonder if you have any thoughts on that, even though that might be a fairly rare or unique situation.
Yeah, I don't know if we've had that specifically, but I think it would partly depend on what services they were accessing. But So I guess just in the case of medical emergencies, yes, or something you deem an emergency, again, you're using your best judgment. And with relation to substance use treatment in 42 CFR Part 2, if you release information in the event of a medical emergency, you just need to document it. You need to say who you released it to, what the medical emergency was, how much information was released. So I call 911 because, you know, so-and-so has overdosed in the lobby, and I'm telling them this person has a substance use issue. Use your best judgment then. With regard to like a teen who's run away, I'll be honest, I don't think that we've had this come up that I'm aware of, but I think it would partly depend on what services they were accessing. So if they were there for like general medical services, then I think it would also partly depend on whether the parents were involved in that situation either. I might have to ask our in-house counsel, because I'm inclined to say that if they're just accessing general medical services and they're not old enough to consent to those services, then I would say that it's probably okay to give that information. But again, I think that you still want to have discussions with the patient of like, look, they're here, they're concerned, you know, but if it's substance use treatment information, without a court order, then, but again, I guess it's just kind of different if they're if they're kind of hiding out at the health center versus like actually accessing a service that day, if that makes sense. Like if they were there receiving substance use treatment services, then even with law enforcement, we're not supposed to release that information unless we actually have a court order telling us to do so.
Right. Gotcha.
If they were just like hiding out there and not accessing services, then I would definitely say that a very clear conversation needs to happen with the adolescent about, you know, like it probably, I think that they're probably looking for a safe place, but it's not that you have obligations to, and they can't just like hide out in the health center. I don't know. I think it would really depend on why, you know, why they're running away and what other services they were accessing. Have any other? Yeah, that is very thorny. I can definitely follow up with our counsel though to see if they have any other feedback on that. But
obviously every situation, like there's not a one size fits all for that that I'm describing. There are a lot of nuances to each situation, but it's, you know, it's somewhat easy to be intimidated by a uniform. Not intimidated, but to be deferential to somebody in uniform, and to the question of, is the patient putting themselves in more jeopardy by being missing than they are by, and so are they using good judgment if they really have run away? I don't remember. Anyway, so thank you, because I've never really asked about it before, but it's always bothered me since then.
Yeah, and I think, and oftentimes law enforcement officers, I'd say often, most times, they do not know about privacy laws. So I think to them, it's just like, oh, well, why don't you just tell me? Give us this information. And so it can create a lot of conflict. And, but I think one of your best options is to really talk with the patient about why they, you know, are missing, or why they wouldn't want someone to know where they are, to see if we can help get them to a better place.
Thank you.
Okay, so this is the next question that we got. So all adult patients on controlled substances need to take a UDS, right? That's the same for our system as well. So the adult's UDS is positive for a stimulant that the child gets from your pediatrician. Is the PCP allowed to tell the pediatrician that the adult may be taking the child's medication? We would say generally no, for a couple different reasons. One, unless there's actual, like, so you look at the rules to break HIPAA, like there's clear like potential for harm or an emergency, then it doesn't really fall under that. And it's also unclear whether or not the adult is taking the child's medication or getting it from someone else. I think we can probably all maybe figure out where they're getting it from. The person prescribing the controlled substance, I think, of course, can follow your other course of action that you would normally take if you're prescribing Lyrica to somebody and their UDS is, consistently showing positive for a stimulant that you don't prescribe and nobody else prescribes, and you're saying you can't take this, it's not okay to take other controlled substances while you're on this and so forth. Then you can discontinue that medication if that's what you feel is appropriate. Some pediatricians are doing drug testing, so they would potentially be able to see in their own drug test if the child was absent for the medication. I think in more extreme circumstances, one thing that our in-house counsel brought up is if the parent was just taking all of the child's medication, which would be probably pretty hard for you to determine without them owning up to it, it could potentially, and again, this is a kind of at your discretion, like in your gut type decision, is fall under child abuse and neglect if they're taking their child's medication, which could then be reported to CPS, and they would probably be the ones to get the pediatrician involved. But that's also a little bit of a sticky one as well. Because even though you're in a shared system, the pediatrician is not treating the adult, right? So it doesn't fall under like need to share information for treatment purposes.
I have a question. Obviously, I don't prescribe, so this is, but I know of a number of providers that I work with who treat children and might be like prescribing ADHD medications, stimulant medications. They actually, their policy that the parents, they request the parents sign this, is that they can also drug test the parent of that child at any time. Have you guys heard of anything like that? And actually, is any questions or any thoughts about, is that crossing a line, and do we need to maybe?
Crossing a line because that suggests, I mean, if you order.
I'm sorry, for whatever reason, whenever you try to talk, it takes a while for the mic gain to get.
I would say that is probably not appropriate because the parent isn't the provider's patient, and they're ordering diagnostic tests on the parent. Like, I get the logic, but I also don't know. That's a little questionable.
That's why the reason why I was wanting to ask, because I don't know. I want to make sure that we're not doing something not good.
Yeah, like when they bill insurance, what are they putting as the diagnosis code for a drug screen? Like,
I honestly can't tell you. Like I said, I don't prescribe or anything like that. It was just something that popped into my head when this discussion was brought up.
I would say, I mean, that would be. I think you'd probably be better off doing. It's tricky, you know. Sometimes you don't know 100%, right? You may get levels back, and it may look like, oh, they may not be taking all their medication, only some of their medication. But how reliable are levels, right? That stuff can vary by person to person. What time they took their medication last? Maybe they forgot it and they ended up taking it later. You know, so there's a lot of different things that factor into that, and you can only do so much, honestly, to control it. I think you can do drug screens to see if it's there for the kiddos, really talk to parents at the beginning about, you know, keeping meds in a safe place. Also talking, if the kids feel comfortable talking to the prescriber, right, about, because our child and adolescent psychiatrist will sometimes meet with the child alone first, right, if it's okay with the parents, and then bring the parents in for the end part of the session to do a joint session. So there is some involvement, but, you know, I don't, and the kid may not know if their parents taking their medication, you know, it's just not, that's why it's also just another thing to be, you know, pretty cautious, and also as best as you can, maybe assess for risk prior to prescribing a stimulant to a kid. Like, what is their household like? You don't want the kid's treatment to be impacted, but is there an alternative that we can prescribe other than something that can potentially be misused by another person in the home, you know?
I think the biggest risk that the providers are putting themselves with is the billing. So just you might want to double check with them if they've found some sort of creative loophole that they're billing the drug screen under so that it's appropriate. Like, I guess technically they may be consenting to the drug screen, but again, is that consenting to a patient-doctor relationship? And then you talk about, well, why is a pediatrician forming a relationship with the adult, a treating relationship?
Well,
really
in a lot of situations here, because the provider sees it's not exclusively a pediatrician.
Okay. So that would be that is, yeah. So then again, it's still like, what diagnosis code are they using to bill for the adult if they're not actually prescribed a controlled substance, and they might get themselves in trouble if they're billing inappropriately.
Yeah, like medical necessity purposes for that individual person.
Yeah.
But yeah, that's interesting. Okay. All right. I think those were all the questions that we had. ahead of time. Are there any other questions that have popped up other than what we've already talked about today?
I just had a follow-up question about the urine drug screen. With minors, my understanding is that both the minor and the parent have to consent to the urine drug screen, but that the results don't have to be disclosed to the parent. Is that correct? Because I think that's what we had said when we had this discussion on our last, when we I don't know. Am I getting that right, guys, from our last echo?
Well, yeah, I mean, I think I wouldn't always tell the parent. I would first approach the patient and say, again, you were positive for pot. This is an issue. You need to stop smoking pot, because if you don't, I'm going to quit writing your stimulant, and therefore your parents are going to find out anyhow. I asked Dr. Fulton, our child and adolescent, and she said, I probably wouldn't tell the parents about, pot, but if it's lethal, potentially, like, they're coming in with fentanyl in their system, God forbid, and they're 13, then she said, her words were, oh, hell yes, I'm going to tell the parent. So whether that puts her, legally sensitive or vulnerable, you can always argue back that I did the right thing for the patient. If this was going to continue, they were going to potentially put themselves at risk for death. So therefore, you can try suing me, but the reality is I did the right thing.
Yeah. Well, I think too, it's going to depend on what the age is, right? So if it's a 7 or 8-year-old who's potentially on a stimulant medication, like that's going to look maybe differently than a 16-year-old in terms of sharing like UDS results. So, I mean, I think you could tell the parent, like, you did a UDS on the kid and it came back negative. Hey, the UDS for your child, like the stimulant came back negative, and these are our concerns. Like, when did the kid take their last dose? Has anybody else had access to the kid's medication, right? Brother, sister. It's not always the parent, right? It could be somebody else. So I think age also just kind of is a factor as well.
Okay.
But I think you can. I think, again, unless they're entering into that substance use treatment realm, like just because you have one positive drug screen does not mean that you have a substance use issue or are you engaged in substance use treatment, right? So I think that's, kind of, again, at the provider's discretion. But I think if Dr. Fulton did choose to tell them about a 14-year-old smoking pot once, or that it came back positive on their drug screen, I don't think that should be violating any confidentiality in terms of substance use treatment services, because that's not the treatment that they're receiving, right? They're being treated for ADHD, and they have to do a drug screen as part of it.
Yeah.
So just to kind of like paraphrase what I think I'm hearing, it's a situation where parents consent for UDS, but if they request, then the results, it's not protected, but it's not something where the provider has to volunteer the information either.
I would ask to know, again, depending on lethality, I may, without them requesting the information, reach out to them and tell them. Yeah. But again, like, if it's marijuana, we know that, especially when we're dealing with adolescents, getting the family involved most times is the best care. So that's why I first would engage the patient and, talking about this with the parents or bringing them in to talk with them, with me in the room, because ultimately better outcomes can be had if the whole family's involved. But when it comes to something that's like a hard drug, then, I probably make different next moves. But as far as me being vulnerable, no, I don't think that puts me at risk. Clear as mud?
And if you all have any follow-up questions, you can always feel free we're on that email chain now, or at least I am, so you can always send those follow-up questions to us, and we'll be happy to help as best as we can. Again, we know it just helps, I think, to bounce it off of other people as well, and I think always just be clear to document your logic. That's the biggest part of it, because sometimes you can't always remember, right? 6 months ago, gosh, I know I made that decision for a reason, and I'm trying to think back about it. So always just document, this is the potential risk that I saw to the patient if I did not disclose this type of information, you know, or even just documenting that you've told the patient up front, we have a shared electronic health record, you know, these types of things may be visible, just to always increase that transparency and talk about its importance, and then cover yourself as a provider too. Yeah. All right.
Guys, are there any other questions? We have about 5 minutes left.
This is Samantha Mann. Sorry I was late joining in. Is it possible to get a copy of the slideshow?
Yes, I can email them back to the group.
Awesome, thank you.
Yeah.
And again, just a reminder, definitely love the copy of that quick fact sheet.
Yeah.
And especially if there's any like sources and citations, that would be awesome.
There are on the fact sheet, actually, it's a West Virginia law fact sheet, but on it they actually cite where they got the information.
That is so cool.
Introduce some like additional.
Thank you very much.
Thank you, guys.
All right, that's excellent. Thank you all for being here. Rachel and Dr. Hackman, thank you again so much for joining us today. Guys, let me see. Our next session, oh, that's the announcement. Our next session is canceled. It was scheduled for April 3rd, but we will be at the CTSI annual meeting, and I think several of you all will be as well. So I just wanted to let you know that psychiatry session won't be held. So the next one ends up being on April 17th. All right? All right. Everybody have a great day.
Thank you.
Bye.